All, can we start? You have a good,
Yes.
nice audience waiting for you.
Great.
Okay,
I have
so
a
well,
good topic waiting for everybody. I hope so.
you do have. So, welcome everyone. Welcome and thank you so much for engaging with us on a Thursday evening post your clinic hours. So, thank you for your continued support that we are able to do this. And I'm so sorry. I'm so sorry for this. That we are on the 11th case discussion right now. So that is indeed big. That is indeed big, indeed proud. So yeah, sorry, I was not able to get this. So we are on the 11th case discussion today, and I'm extremely thankful to Anupama for taking up this invitation, accepting this, preparing this, because each of the speakers, they do put in a lot of effort in getting the presentation correct for to be able to get through to all of us. I'll quickly introduce Anupama so that we can get on with her presentation. She has completed her MSLP from TNMC and has been a clinical practitioner for the last 14 years now. She is the founder and a speech swallow therapist at IU Multispecialty Clinic, and she specializes in speech and language therapy for pediatrics, adults, for boys, as well as swallowing disorders. She is a consultant speech and swallow therapist at Tunga Hospital and Criticare Hospital, and she has also conducted multiple group sessions for adults with Parkinson's disorder in collaboration with PD and PDMDS. So, should I be sharing the screen or do you want to?
I'll share the screen.
Please go ahead. Please go ahead. I can share it. Let me know if you need help.
All right. Just give me a second.
Huh.
I am very good at all this.
Evidently,
Yes, yes, yes. Believe me, phone is easier.
phone doesn't give you so many options.
Hana, Sachi, I didn't realize I was so bad. All right. Can you see the screen right now?
I can see the screen, but you need to go on the first slide and go to slideshow mode. If you're not able to
Okay.
do that, I'll try doing that.
I am already on the slideshow mode.
So I'm not getting that. This has been happening for the past two times. It is with the version of the PPT. So
Acha.
you stop sharing, I'll share immediately.
All right, all right. Fair enough.
Okay,
One
I'll just,
second, 1 second. Debo, let me
yeah.
just and now let me see. Okay, tell me, how about this?
No, it is yet to come on the screen.
No, she cannot see the full screen.
I can do it. I can share it. Wait,
All
I'll
right.
do it.
In that case, I would ask
No,
you
not an issue at all.
done.
Just tell me if when I am going on slideshow mode, if you are able to see the full screen. Is it
Yes,
okay?
yes, yes,
Okay.
yes.
Please go on. Please go
Okay. So, all
on.
right, everyone. Good evening, everyone. Thank you for bearing with me because my knowledge about technology, I guess, is very, very bad. So, anyways, today we are going to be talking about importance of understanding sensory integration for SLPs. I have been doing speech and language therapy for pediatrics for the past 14 years. So, and over the time, I have realized that knowledge of sensory integration is so important for SLPs as well. Why is that? You'll understand in the case presentation that I'm doing today. Having said that, post COVID is something that I have realized that because during the COVID period, what has happened is children have not received lot of sensory inputs. because of being they were not allowed, not much mobility was there. Children were at one place watching TV or screen, too much of screen time, and because of that the sensory input had reduced. And post that, the children that I am seeing for therapy, I realize that the amount of sensory processing disorders have actually increased that I used to see before COVID. So I thought this would be a good topic for all of us to understand. And we as SLPs, what are the things that we could identify, or what are the symptoms, red flags that we could identify, so that we work in collaboration with the occupational therapies, with the SI therapist, so that we get a, give better output to the children. All right. I will start with the presentation. Okay. So this is a 6-year-old female child. They had reported to us in December 2023 with a complaint of inability to speak or understand spoken language. There was no, as reported by parents, there was no significant prenatal or postnatal history. Now, on speech assessment, it was noted that the prerequisites for language learning was poor. There was no oromotor abnormality. Vegetative functions like blowing and sucking were affected. She comprehended simple one-step command, but she required physical prompts for those. She recognized her family members, but then she would not recognize them with their kingship terms. Poor comprehension of daily objects, expression was limited to just crying, or she would drag occasionally to the desired object. Now, the signs that I noted and I felt that, okay, we need to speak to the SI therapist was she was either crying or she was closing her ears when the loudness would increase, either my loudness or any loudness of any toy or the children who were sitting outside. Second, she was constantly holding her parents' hand or squeezing their hands. Then, as reported by parent, there were multiple instances that she would just take roti from hot tawa while it's prepared when she's hungry. Then, poor instruction following, awareness of the environment, poor motor planning, even to get objects. Her planning was very poor. So finally, I asked our occupational therapist to do assessment for her. And as per the occupational therapist assessment, she had poor to fair age appropriate gross motor and fine motor skills. She had concerns with visual perception and cognitive skills. She had auditory sensitivity. And according to the sensory profile, she had difficulties in the auditory, vestibular, tactile, and oral sensory processing. Her endurance, tone, emotional, and social responses and behavioral areas were also involved. Now, when the child came to us in December 2023, the child was 6 years old. And the child, the parent had noticed difficulty at the age of 2.5 years. So then they went to doctor because there was delay in her speech milestones. They went to doctors, pediatricians. And then ultimately, they started with multiple therapies, whatever they were guided to do. They underwent occupational therapy, they underwent physical training, they went ABA therapy, aquatic therapy, and speech therapy at various centers. Now, as reported, parent that reported to me that she used to cry in all the sessions. I'm assuming now because of her auditory defensiveness that she was crying in all the sessions, most of the sessions, and not much difference was noted during the session or post those sessions that they had taken. Now, at that point, I had, because there were multiple therapies going on, it had also affected the parents well-being, mental well-being. So I had counseled them to stop all the therapies and start with SI program, because post what our occupational therapist mentioned to me, she would require intensive occupational therapy including sensory integration program. So I had asked them that they will have to stop all the therapy for 3 months and just focus on sensory integration program. Of course, parents were hesitant because they did, of course it's difficult to believe me suddenly and stop everything that they're doing for the past 3 years. But after a month, they got back to me and they agreed to do the same thing. So then January 2024, we started with her therapy. For 3 months, it was just SI program along with occupational therapy that was followed for her. And she showed drastic improvements. That post 3 months, we started with her speech therapy. And because parents were saying that she's interested in swimming, so then they also enrolled her in swimming class near their house. Okay, so this is too much on one page, but I will tell you about the progress. This is just to see progress in occupational therapy that we had noted in 3 to 4 months. Her sensory issues had reduced. The defensiveness to loud sounds had reduced. Of course, still, if you give continuous loud sound, she still had difficulty. Either she'll put her fingers in her ear, but she had stopped crying to any loud sound. Second, squeezing someone's hand on sounds or that tactile seeking had also reduced. It had not completely gone, but it had reduced to a great extent. Her motor skills, gross motor skills, fine motor skills, jumping, throwing had also shown, she had shown a great improvement in all of these areas. In fact, today the parent called me and told me that she's sitting and writing paper only with the support of shadow teacher. Shadow teacher is not helping her to write. She's writing independently. Shadow teacher is asking the or saying the question and she's writing independently. So to that extent, this I'm talking about almost 10 months later. Fine motor skills, she had shown improvement in her fine motor skills. Visual motor and visual perceptual skills had improved. Shape recognition, identification, color identification improved. Her cognitive skills also improved. Girl who was taking food or a roti out of a hot tawa. Now she knows, she understands that this is not safe, this is safe. That understanding and discrimination, that planning has also come now. All right. Okay. I really wanted to focus on the speech part of it because my whole idea of presenting this was because they have been taking speech therapy. They've been going to multiple places. In fact, they've also visited outstation therapists because thinking that there will be a progress. But because there were so many sensory issues, she had tactile issues, she had auditory defensiveness, she had proprioceptive difficulties. Because of that, whatever approach was used, it was difficult to overcome that barrier and improve her abilities like imitation, beat pointing, beat communication. Post this sensory integration program, I could, when we started with a speech therapy for 3 months, we started in March 2024. In June, July 2024, we could see that her communication is improving. It till that time it was still not pointing, specific pointing, but her babbling had come up. There was more of speech imitation, not precise speech imitation. I would say a word, she would make a sound or something which is close to it. Occasionally, 1 out of 10 times, maybe she would say the right word, but not every time. Then physical imitation. She had started physical imitation, but again, that was very poor. But now, as of today, her physical imitation is very good. In fact, she is able to do a physical activity just on demand. If I tell her clap your hands, she is able to do that. If I tell her put your hands up, she's able to do that. Then there are a lot of words which is coming up, though she says a lot of words on imitation, but the consistent ones are mama, papa, bye, hi. So if you say a hi loudly, she does say a hi, but again it's not consistent. And mama papa is also not, though out of throughout the day, maybe once she'll call out mama just because she wanted something, but still it's not consistent throughout the day. But she's using a lot more words, and on imitation, her verbal imitation has definitely improved. So these are the changes that we can see in the last 6 months of speech therapy due to the SI therapy that was started for her before speech therapy. Okay. So now I'll talk a little about sensory processing disorder. This is the information that, of course, thanks to our occupational therapist at my center, Dr. Anita Ganesh. She's always guided me and helped me understand the sensory processing disorder, and that is how I have been able to help patients also. So, what is sensory processing disorder? It's the inability to use information received through senses in order to function smoothly in daily life. Now, it's not one specific disorder, it's actually an umbrella term to cover a variety of neurological disabilities. Now, what happens is when processing is disordered, brain cannot do its most important job of organizing these sensory messages. And that is why these children face difficulties. Now, difficulty in using sensory information to plan and carry out actions that he or she needs to do thus makes it difficult for them to learn a skill or learn multiple skills that is required for communication, speech, writing, day to day activities that gets affected due to that. Next. I'll this. Okay. So now, as speech therapist, now when the child comes to us, we do speech language assessment, we do a oromotor assessment. Along with that, these are certain signs that we can look at. So we understand, okay, these are some certain things wherein the child may also have an underlying sensory processing issue. They have trouble concentrating or focusing. Attention is one major thing. Some are overly sensitive to sounds and some are under responsive. They have trouble with fine motor skills like writing and cutting. They complain about tags on their clothes. In fact, you'll see a lot of children who will keep scratching if that tag which is there on the t-shirt or something, if it's there and keeps touching it, they'll keep scratching. I have kids who've actually, bruised themselves scratching. So that is the level of difficulty that they face. I cry and shield my eyes from the sun and other bright lights, having visual defensiveness. I am challenged by gross motor skills such as running or riding a bike. I hate having my hair brushed, washed, or cut. I don't enjoy being cuddled or tickled. I chew on everything. I'm a picky eater and don't like new foods and textures. I walk on my tiptoes. I seem to be unaware of normal touch and pain. I often touch others too soft or too hard. So these are the signs. If the parents say that these are the difficulties that he or she has, along with the speech language difficulty, of course, see, initially they will come to us with the complaint of speech difficulties. But these are certain signs. Along with that, if we notice during session, during assessment, also for example, auditory defensiveness, it's something that is noticeable. Once we increase our loudness, you see them closing their ears or crying or wanting to get up and move away, or you see the child not wanting to get up and get something. They're comfortable sitting in one place, they're not ready to move around and find. So, and there is another group of children who would just want to move around and not sit at one place. So there are multiple other things that we can notice during assessment, and then get in touch with occupational therapist at our center or any other centers, and in collaboration with them, or we could ask them to do a screening or the entire assessment for sensory difficulties and then work accordingly. Okay, so now what are the difficulties that is usually noticed? There is tactile dysfunction, there is vestibular dysfunction, proprioceptive dysfunction, visual dysfunction, and auditory dysfunction. Now, in tactile dysfunction, the child could be either over responsive or under responsive. When it is over responsive, what happens? The child does not like anyone's touch. So that is usually the case when the child is over responsive. When the child is under responsive, what happens? The child usually seeks for it. So you will see the child either pinching or squeezing and wanting to, hug or something like that. So they want that tactile, they seek touch. So this is usually case with under responsive tactile dysfunction. Vestibular dysfunction, again, same thing. The child could be under responsive, over responsive, or there could be gravitational insecurity in the child. So, if the child is over responsive when it comes to vestibular dysfunction, what happens? The child, you will see the child preferring to sit in one place, not move around much, does not like swinging. They don't prefer swinging. You make them sit on the swing, they'll cry. Under responsive ones, they will seek all this. They will seek vestibular things, like sitting on the swing. You make them swing fast, they actually like it. And children with gravitational insecurity, they will have, they you will see them having even balance issues. They, you make them stand for some time, they will start crying. You will see them having balance issues as well. If you make them, hang them the other way, hold their legs, they will start crying. So these are certain, when they're off the ground, basically when they're off the ground, they have difficulty. So that is gravitational insecurity. Proprioceptive dysfunction, awareness of their body in space, basically. So again, they could be under responsive, over responsive. Here, if you see, that is the reason imitation becomes a difficulty if you see the child having difficulty in proprioception. So they will not be able to imitate. Physical imitation will be a difficulty because the coordination is affected here. Also, if the child has proprioceptive dysfunction, they will have a difficulty in regulating their emotions as well, because if they are under responsive, they will not be able to judge or respond to a situation appropriately. So that is why you will notice either poor emotion, or either they're very aggressive for smaller things, they tend to be hyper or overly react to certain things. So that emotional regulation is noted when there is a proprioceptive dysfunction. Visual dysfunction, again, the example that we saw, the signs that we saw, that light, they do not like it, or they tend to close their eyes when there is bright light. So there is either visual defensiveness or seeking. So they'll, some children tend to seek light. You switch on the light, they'll look there. So these, both ways, either they are seeking it or they are defensive towards it. Similarly, with auditory dysfunction, they are either defensive to it or they are seeking auditory. Some children will continuously make noise during the session. Either they will produce sound, loud sounds, or they'll move the object, screeching sound. They prefer that because they're seeking it. And there are other group of kids, if you make a sound, loud sound, or even if you are singing, they don't like it and they tend to close their ears. At times they cry. So the severity of difficulty is different from child to child. But then also we have to note one thing, that we all may have some kind of sensory difficulty in some form, not necessary to a larger extent, but some form. But we are able to function without any difficulty. But when that is higher, the child has difficulty learning a skill. When the child, for example, now when the child has auditory defensiveness, now what happens, because every sound is troubling the child, it's difficult for us to start with any kind of verbal imitation, because the moment you start with any verbal activity, the child tends to close its ears. The environmental awareness becomes poor, because the moment the child is in a group of people or he goes outside, the first thing is close ears or cry. So then automatically their learning is affected because of that. The learning is inhibited because of that. So then this causes a problem in that learning process for them, or in our training process. Okay, so now what do I do as an SLP? Okay, I found out these, that there are these difficulties. So it's important, like I already mentioned, that along with oromotor speech and language assessment, it's important that we check for these other signs and symptoms that is exhibited by the child. If warranted, involve a speech therapist for sensory integration therapist for detailed evaluation and plan appropriate strategies in collaboration. Many of like I mentioned, many of us may present with some sensory issues. It is when they begin to affect a child's participation in daily tasks that it becomes a problem, and we need to do some intervention for that. Thank you. Open for question.
Unbelievable. I thought you'll have more.
Ray, I had lot more, but I had to cut down.
Okay, so because we were discussing about the problems that you generally experience in the session, I think we can open it to the audience that what you have faced and what all strategies you have used for making your session a success. It will be highly appreciated if you participate. So the last point that you were saying, I clapped beside a child today and he jumped up and he was outside the session. I just clapped. So I had to bring him back by telling one of the strategies that I would prefer using is that I visually then show him because this was specifically an auditory dysfunction. I specifically showed him that so this caused me trouble. And instead of the exit strategy of getting up and running, I can tell you or I can show you. So the same kid, when he starts crying, he himself is so troubled by the sound of his crying, he closes his ears. But he cannot inhibit the crying process because something has troubled him. Whatever, a parent might have said a no or something. There are thousands of reasons why he can go into the crying and not come sort of out of it. Another point, because you were listing it, I would want to tell you that as a speech language pathologist, one of the easiest things that we can notice in a session when you are dealing with a child with sensory processing disorder, irrespective of other comorbidities with which the child has come to you with, either the child is super defensive on where he's putting his legs, his feet, or he will kick everything, he or she will kick everything on the way, and there is no cognizance to what I have kicked, where it has flown out, or if something has even fallen down from my hand, there is no visual coordination to, okay, that thing fell down from my hand and it has, gone somewhere. So the kids who are attending SI and OT, it is much easier to get their attention that, see, you have kicked a box of cards or you have kicked a whole bunch of blocks, can we get it back? So when we help them to look, because like you said, then the verbal instruction makes sense to that kid when we are telling them. Otherwise, they are likely to have a completely different reaction,
True.
basically.
True, very true, very true. In fact, that is the difficulty. See, like you said, so that becomes a proprioceptive difficulty that we are not aware of the objects that is lying, and then we tend to kick and come.
Correct,
So these are certain difficulties which
correct.
maybe 10 years back I had no idea. So
Correct.
we as
It was all
therapists,
a behavior. It was all a behavior that this has to be stopped. The parent is also complaining of something, and the response from us would be, okay, this has to be changed or this has to be stopped, without really understanding that what other processes could be going on.
involved. True, true, true.
Correct.
Very true. And
So,
now the changes, for example, stimming, visual stimming that they do,
correct,
or seeking for things. So now we know
correct.
we have an option of putting weights on them. So then they calm down, and we see
Yes,
that changes that without actually shouting or forcefully making the child do
absolutely.
something, that has already calmed the child down, and we could do our activity without it.
The forcing or getting the child to understand a no has never helped. So like you're talking about stimming, older kids who are now 14 and 15, they have actually told me verbatim, I'll tell you. So I was counting the dust particles in the sunlight and I just could not concentrate on what the teacher was telling me to write. So he was describing an incident from the time he was 8 years old and now he's 15, and you feel said that, and you actually understand that at that time they did not have enough language to organize their memory and thoughts, and today we have helped them to the level that they are able to tell me, so I was there and you were telling me to do this and this was not happening. So after working for quite a long time, I actually asked this fellow that then how did you manage to work with us? His answer was so to the point, you know. You help me to understand that the thoughts that you are not addressing, or this visual dysfunctions, and he had a lot of other things on it, that whatever you are not addressing is not going away. I can still go back to it, and I have it. And if I have a problem, I can come back to you. So the younger I was, I kept thinking, you know, you're forcing me to do this and you're not allowing me to do this.
Hmm.
So that brings me to the next point. So whenever we deal with children, because you said, you know, as SLPs, what we need to do, the training is definitely one for the parents to understand what could be the the reason this could be happening and what all could be done. Like you said, if it is stimming, you could be putting weights. If it is stimming, you could provide options for stimming, like, you
Correct.
know, instead of fingers in the sunlight, you could provide more toys. It could be sensory, it could be a bus also, it could be slime also, depending what is the child's this thing. What I put to the parents, you know, as a next step is, tell the child why you did it. Tell the child, and not in a manner that, see, you controlled your fingers because I gave it to you. No, but it made you happier, because the moment you give this, it helps the serotonin and the dopamine level to the extent that they are able to focus on you, they are able to regulate with you, they are able to co-regulate with you, and they are able to learn some skills. So
Correct.
what is of vital importance is, you pass on this message to the child, because if you keep doing that as a habit, in 2 years time, what I've observed in the last 5 years is, in 2 years time, the child starts telling you, I need a movement break now. I need to go outside. I've actually had a kid who said that I need to go outside and smell the gobar and come back. I'm not kidding you. This was in the village. The parents, that's how they understood the, the olfactory dysfunction, that why he is so this thing to certain smells. So the important thing is, you train the parent. You train the parent to pick up the triggers. You train the parent in understanding why there is so much of crying, or why there is so much of defensiveness, and you give alternatives. The autist is also giving alternatives, but it is equally important to somehow communicate to the kid that this is the alternative which has worked for you and which has made you happy. Nothing else. It made you sit, it made you listen to me. No, I think if that is done, it is
It is
better.
true, true. It is better. It is better and helps us a lot.
It does. It does, because the child's functioning is improving. So
Improving.
we have two things in the chat box. One is from Lakshmi R. If we start speech therapy along with OT at the same time, suppose the parents wanted both therapies, what strategies can we incorporate as an SLP in the session?
Okay. See, usually if it depends on what is the level of difficulty in the child. Now, the
Correct.
child that I was discussing about, the level of difficulty was too much, plus the bombardment of therapies that went on for so long also was too much.
Ah,
So, parents' mental health was also affected because they were constantly working on too many things. Every therapy center or every
hmm,
therapist that you go to guides you with some activities or some techniques to work with, and
correct.
everyone expects the parent to do it, which is
Correct.
obviously the way. So now what happens when they go to multiple places or multiple therapies, then multiple things are supposed to be done and parents
Hmm,
get confused and do not work on anything properly.
hmm,
So at when I assessed this child, I knew that we have to focus on certain very limited activities because the child also needs to get her free time to explore things.
correct.
So
Hmm,
then that was the reason why I suggested that 3 months of only SI therapy along with occupational therapy. And then, of course, this was also after discussing with the occupational therapist. It was not my own decision, but with discussion, when I discussed it with her, she also suggested the same thing, that we should start just this for now. Let them follow up with those activities at home and we'll see the difference. And we could actually see the difference in 1 month's time because the
correct.
other things were cut down.
Hmm,
Parents were just focusing on this activity or following up these activities very well at home, so we could start seeing the changes. So then we were also sure that okay, let's follow the same program, and we continued the same thing for next 2 months, and then started with her speech therapy. For there are many more kids who come to us when you know that okay, we can teach them a skill, simple imitation skills, even for
hmm,
a second if they can pay attention, or we could do movement exercise and make them sit and do an activity. Even that, if that is achievable, then I take the decision that let's go ahead with both the therapies, occupational therapy and speech therapy, simultaneously. But the difficulty, if the difficulty is too much that whatever we do we will not be able to help the child, then I suggest them that let's start with occupational therapy first. If SI
Hmm.
is required, then SI therapy along with it, and then move on to speech therapy once the child, we can regulate the child at least for 5 minutes.
Correct. So, to add on to your answer, if the visual dysfunction is like it's not much, you can use a lot of visuals to help. So,
So,
I am adding to Anupama's answer. I will just share my screen where visually it works. Anupama, there are two more things in the chat box. I'll just show you because this has been working. I am just sort of excited to show you this. It works when used properly. One second. Where okay, there are too many things open. So I want to tell you that this does not work, what she said. If you tell the kid you're not going to run, you're going to sit, it does not work. As against that, when you give options, like instead of pushing we can squeeze a ball, instead of touching we can squeeze the clay. If such options are provided, demonstrated and persisted with parents at home, these these are incredibly useful.
true.
So what can you do? Tell the child what can you do instead of what you can't do. I'm sorry. Then this thing. If the parent is doing this activity with the autist and you know pressure on the hands is going to reduce a lot of pinching or hard pulling or soft pulling, you can tell the parent to do this in the waiting area before your session and you're going to see a drastic change in this. Just chasing a ball or chasing a car in the waiting area and then sanitize your hands. And I'll just give you all the options which definitely works. Like she said, incorporate a movement based or a music based activity. You can actually have rhymes or not have rhymes depending on the auditory issues that the child has. But show the kid that we are not going to sing. You can have such movement either with the mom or with you if you are not able to do. If sensitize the mom, if the mom is persisting at home, she will do it for you at the clinic also. Then anything, jumping off a stool, jumping off a mat, jumping off the bed, and even this. Because I think one next question is about lying down. We're going to come to address that. I just wanted to tell you that you have, for some kids where it is not visually working, you have to do it. You have to do it and they trust you that you are going to follow through with that. So Savani ma'am says for children who have auditory hypersensitivity, does white noise masking help to desensitize? And how do you decide the schedule?
So, ma'am, I haven't tried that. If the child has auditory difficulties, either hypersensitivity, mostly if the child has auditory defensiveness, is only when I take help from, of course, the occupational therapy is going on, but I do not stop speech therapy because the child is auditory seeker. If the child is
Correct.
auditory defensiveness, has auditory defensiveness, then we ask the occupational therapy to work on it. I have never tried, but there is one child on who's undergoing therapy for the past 3 months, has severe auditory defensiveness. He has picked up language, he has picked up speech well, to the extent that he is speaking in sentences, he is asking for whatever that he wants. Need based communication is very good. He answers what questions, where questions, who questions as well. But social participation is a problem because of this auditory defensiveness. So right now what the occupational therapist is doing is she's trying to integrate his senses. That has shown some help, but still, in school he's still facing difficulty. So the next thing that we are going to plan is try a headphone with soft sounds and see if that works for him, if integrating the senses is not helping him. So otherwise I have not tried using white noise. I completely rely on occupational therapist for it.
Mm, many kids do benefit depending on the parents trying it. Very truthfully speaking, many kids do benefit, and truthfully the parent, it is the schedule of the parents. Some of them use it while they are falling asleep. Some of them are using it while they are doing another route-based activity where the child does not need to listen. But what you said that, when the OT is trying to integrate it, so when the child is facing a loud sound in a softer volume, basically, when it is a controlled situation, you can try, the OTist will only tell you this. This is how we can do it in our session. You can try giving some other proprioceptive or kinesthetic input. You could be giving deep pressure. So when you the wheelbarrow picture that I showed, so when the parent is doing the wheelbarrow, so there is a lot of kinesthetic movement input which is going in through your joints, your elbows and your shoulder. Then if the child is exposed to noises of different intensities and frequencies, the their tolerance increases. It may not they will not be completely desensitized, but definitely the tolerance increases. Same thing. So if they're interested in playing with clay or soaked sabza, the gel-like thing, and you have the music playing, your nervous system is not getting overwhelmed basically. So your autonomous nervous system is in control at that time. So you're not in a fight-flight situation. And if when you introduce the harmful stimuli, but in a lower intensity, it starts working. So this is what she meant by this is how the autist will
Integrate, correct. Therefore, I want to
integrate.
add something here. What
Please do,
happens
please
is
do.
all this in individual session becomes easier for us to achieve with
Correct.
the rest of the techniques that we use.
Absolutely.
Now, like I mentioned about this child, the problem arises when he is a part of the group. So that is the time, because school, we
Correct.
cannot control any situation there. So then
Absolutely.
that is the time it becomes difficult. So at this point, when the child had earlier gone to school, he would just close his ears and cry. At this point, he will just stand aside. He will not
Correct.
enter or be a part of the group.
Correct.
So, but then again, I think working that way. But the next step is headphones, that, like I mentioned, some of the schools also provide headphones or these foam
Mm-hmm.
plugs
Correct.
to help the child. But again, since I have not used it for any of the kids till now, also one interesting thing that I have noticed in terms of be it auditory or visual, that some child are seeking when they come to us or when they start therapy. We see that the child is seeking auditory things. He's pulling the table or making sounds or
Yes, 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 yes,
suddenly after some time you see them becoming auditory defensive,
yes,
that they don't like sound. So somehow, because we are trying to integrate or one process or one sensory difficulties, I'm not sure if the other one,
yes,
uh, there is a difficulty due to which you see an increase in this or overload here. But there are these changes also that I have
yes.
noticed over the period of their therapy sessions.
So, this is most a lot to do with the cortical representation also, one. And the second thing is this is absolutely, it may not be a very correct comparison, but this is what you see even in hypotonia. There
Hmm.
are going to be changes in tonicity to the extent that the physio or the occupational therapist cannot work that day. The child is in such a hypertonic state, basically. So it is not that if there is one, there cannot be the other. It
No.
even that is on a spectrum of its own existence, and the reason I told you to keep making the child aware if a particular solution works, so that the child is able to tell you today it is this or today it is that.
Hmm. Hmm. Hmm.
Okay. So that is also very important. It is never the same state always.
True. True.
So Vindhya is asking if a child is laying down and licking the floor always, how can we reduce such things? Okay, there's an exclamation and a question mark. What are the strategies to improve speech and language?
Okay. Firstly, again, if the child is lying down continuously, again, his proprioception must be poor. So then that is one thing we need.
Insecurity. It is
Yes,
definitely correct.
yes,
Correct.
yes, yes. So that is one thing. Plus some oral motor issues as well. So we
Ah,
can start working on both the areas, giving the child swing, movement activities,
correct.
asking the parent to do those activities before they come to the center.
Absolutely.
Make the child swing or jump as much as possible,
Correct.
and then get the child. So these things really help. One. Second, oral exercises,
Correct.
blowing exercises to to a great extent also helps in these areas. Now, here the child may be lying down and then, you know, so that could have, the licking could have been because of that. Otherwise, he tends to eat the other non-edible objects. I am not sure.
Correct.
So, if it's a general thing, but we can
So,
work on these areas.
So, like you said, listing it out, what you said is two things. If the child is coming to the speech section and doing this, there is a lot of parent education which has not happened. The parent has not been told what are the issues. And if you have gravitational insecurity, for that matter, any of the SPD symptoms that Anupama has just covered, please remember it is going to affect the arousal level of the kid. Okay, it is like if I wake you up from very deep sleep and ask you to concentrate on something or do something that you generally do, you're excellent at doing, your system has not kick-started, your melatonin is not where it is supposed to be. So remember, any of these issues of your nervous system is going to affect your arousal, your capacity to concentrate,
Okay.
imitate, and work. That was the core content of what she was saying. So if she is lying down, it is not just that she is lying down, but her arousal, her intent of concentrating, looking at the environment, everything is affected. So the child, the first is the parent education. Then please do these XYZ things at home before you come. And secondly, even the play level, if the curiosity level of the child is still oral, it is very difficult to then work unless the parent is following up. I'm not saying do the OT first and then come to speech, but if the parent
Yes.
can work, if you can train the parent, if the parent can work, and then you can have the session, or after the parent does that, the parent walks with the child to your center. If there is a staircase, can go up and down with with 1 liter or 2 liter water bottles on the backpack. You
Yeah.
don't even need a jacket. You just need a backpack. You might be able to see a lot of change. Good communication with the occupational therapist, telling them that please educate the parent about the child's overall state, is definitely going to have, get the parent, let the parents have a handle on what is
Good.
going on, basically.
I would actually like to add here because on multiple occasions I have had this discussion, or rather argument, with colleagues or SLPs, my
Correct,
friends rather, that we should not, about the whole controversy on, we should not ask them to, occupational therapist first and then
correct,
speech
correct,
therapy.
correct,
It's not that speech therapists don't help. It's not that way. So of course we have to work hand in hand after seeing, like I mentioned before, that post covid these difficulties have literally come up to a very great extent, for
correct,
simple reasons, because during covid they were not given, they did not receive much sensory input.
correct.
Play was not there. There was no going to the park, no going to the garden, no play time because parents
Hmm.
were busy with their work. So they all that they had was screen time. You
and
know
and the usual exposure, like
that the
getting
child had.
getting brushed on even your walls and falling down on sand and things like that, getting up and down the staircase, getting the basic movements of your knee
Mhm.
joints. We were talking about things even as simple as this.
Basic
This
as
has
that. True.
definitely. There's
Yes.
one more in the chat box, Anupama. I'll read it out for you. It is from Sushri Smita. ADHD and SPD can often co-occur, making it more challenging to diagnose each condition separately. Many children diagnosed with ADHD also have sensory processing difficulties and vice versa, without distinguishing between which behaviors are driven by attention deficits and which are due to sensory processing challenges. How we as speech therapists diagnose the condition, or our diagnosis is going to be based on uh, psychologist or pediatrician and behavioral assessment. What is your take on it?
See, psychologist. Uh, I don't rely on their judgments for, in terms of to identify or differentiate
Psychiatrist.
between.
She meant a psychiatrist,
Acha.
psychologist and a psychiatrist.
Okay, okay. Again, I do not rely on their, assessment to
Hmm,
differentiate between ADHD and SPD. Again, you correctly said that it can coexist. If a
absolutely.
child has proprioceptive difficulty and the child is hyper, then you will see that hyperactivity. So
Correct.
the child is also labeled as ADHD. If the
Correct.
sensory profile is not done for the child, the child will be labeled as ADHD.
ADHD.
So that
Absolutely.
will be the case. But when we see, again, in pediatrician, it's difficult for them as well to identify or distinguish. They can, most of the time, the pediatrician, recently I have noticed this. So the ABA therapy that was mentioned to the child that they had started, the child that I had mentioned today in case discussion, they were mentioned that the child should undergo ABA therapy
Hmm.
because she has behavioral difficulties.
Correct.
So this was the suggestion that was given. So like I said, we could see the signs.
Hmm.
We cannot rule it out completely, because
Correct.
the right person to do it is an occupational therapist with
Absolutely.
sensory integration knowledge. So the right person is that. Now again, there are occupational therapists who are not sensory integration therapists. So
Hmm.
their approach, I have seen a difference in their approaches as well.
Correct.
So that is also noted. So it's better that if we feel that okay, this could be sensory processing, then we could ask them to rule out, do a detailed assessment,
Hmm.
and then ask them to rule out. I will not rely on psychiatrist or pediatrician or
For the
behavioral
diagnosis. Correct.
therapist. Yes,
So
yes.
I think Vijaya ma'am wants to say something. Ma'am, do you want to unmute yourself and speak,
Yeah.
please?
So this is a wonderful, wonderful topic. I must congratulate you on your choice of
Also, speaker.
topics.
Yes.
Thank you.
Yeah, absolutely. Anupama, you've done a fantastic job. See, a
Thank you.
lot of awareness has come post-COVID on this. So I was listening to, I think she's called Jessie Ginsburg, the sensory SLP on Instagram. She used to do a lot of sessions during COVID. So there
Hmm.
was one very interesting point that I learned from her. So she was saying that, see, after having worked with the children, the gist of what she said was you get an understanding of the arousal level. So if
Hmm.
you have a child who is hypo, then you start your session on a higher note. So you start off with, say, maybe putting the child
Yes.
on the ball and you
Yes.
do a rhyme, keep your lights bright, have
Yes.
lots of printed, what is that called? Posters and
Post.
stuff on the wall.
Correct.
So you
Correct.
bring the arousal level high. But the
Hmm.
vice versa for a hypo child. So if your child is hypo, make sure, I mean, if your child is
Hyper.
hyper,
Type.
then you
Ha.
make sure
Correct.
your voice is low.
Subtle.
You are not extra animated. Your
Correct.
lights are dim and you start the session with joint compressions. So
Correct.
this has
Yes.
worked very
Yes.
well. See, now, honestly speaking, I don't do one-on-one sessions. So these are inputs that I have given parents and it has worked very well. So this is one point that I want to make. So it is not like, see, not always possible that we have a multidisciplinary team under the
True.
same roof. So if
Absolutely.
we can pick up those, those ideas and those principles and integrate them into our sessions, it works well.
True.
Another point is, I think we also, through these sessions are educating ourselves
Yes.
to understand why we need to do what we are doing.
Hmm.
Absolutely, ma'am.
True. True.
Absolutely.
Yeah.
You're
So
hitting the nail on the head.
I
Yes.
I use a very, very crude example with my parents. I'm just sharing it here. This is what has worked for me. Okay.
Yes.
So I tell them, see, now you want to use a restroom urgently. And at that point, if biryani is your favorite dish or ice cream is your favorite dish, if I give that to you, would you appreciate it? Immediately the parent will say no. So I said, that is the kind of trouble your child is having. That
Always
sensory
struggling.
issue is what is gaining the importance, not the input
Correct.
that you and I are giving. So
Give.
this is how,
Correct.
it kind of has a great impact. I don't know where I came up with this example, but this is something I think most of us understand that.
Correct.
Because as I have understood, wanting to go to the restroom is one of the strongest things that you
Urges.
cannot.
Yes.
Yeah,
Yes. Urges
yeah.
you
So
can
that is,
have.
yeah. Yeah, so this is one point, and another point I think we really need to educate parents is cramming the day child's day with excessive
Yes.
activities.
So
So
true.
this is something we have to cut down on because the children lose out on their childhood. But for
Correct.
that, what we need to give them is robust home training programs using very simple tools and toys which they can carry out easily at home, and
Absolutely.
make sure you give a good logic as to why they do whichever activity is it that you want them to do. I think these
Absolutely.
are points that make us effective therapists.
So
Ma'am, could you name?
Yeah, her name
I
is Jessie Ginsburg. Jessie Ginsberg. She is called the sensory OT.
Okay. Ma'am, following up on what you just said, like with a hypo child, you start your session with a at a very
Higher
high
note.
note. For yes, just for as an example for the audience, I'm just specifying. When you have a kid who is jumping off the sofa, jumping off your receptionist table, like we were talking and discussing, getting the parent to give deep hugs, getting the parent to do a wheelbarrow walk is so massively helpful before your session starts, because the parent is also in a habit that when I want to do some literacy based activity, this is what is required, instead of the parent getting frustrated that you guys managed to do it somehow and I have no idea what to do at home. So the one which Vindhya mentioned, that the child is just lying down and licking in the session, you realize that the parent education is missing and it is so lacking that, the wherever physical therapy is going on, the parent has not been made aware about the child's state
child
at all, that you are battling this. So the education, like ma'am said, and the robust reasoning that you give, you actually talk about the nervous system, you actually talk about this going for your urge to go to the toilet and smelling the biryani, for them to understand the struggle that the
the
child
child is
is
going
is
through.
going through. Absolutely. Absolutely.
Because
So
I think
I'm
we
sure
need to
everyone is
be
familiar with one
Anupama,
sentence.
can I just take a minute? I said we need to be our children's strongest
this
advocates.
advocate, always,
Yeah, so they
always.
are not our patients, they are our children. So we have to be our children's strongest
Absolutely.
advocates, because parents, when they come into our rooms, they have this habit of saying, he doesn't do this, he needs to do this.
Yes,
The list of all the complaints and needs to do is big, much stronger.
yes.
So, first, I think with the first step, we start off with focus on the positives, show them what is it that your child is able to do, and then I think beyond a point, you should start saying, stop complaining. Let's get to do what we're doing. That I
Absolutely.
think is what we need to do.
Ma'am, my child is moody. He will do when he wants to do. So the inconsistency, and he's very stubborn. So I battle these two by saying that he or she is curious, he's digging in places where you are not being supportive. Why don't we try looking at it like that? You are not being supportive. We are as adults not being supportive. So let me teach you how to support to get much better quality of life with the kid, ma'am. This is how even I start that, instead of being stubborn and doing this, because there are a variety of these reasons why your child is behaving as she is behaving. Another point that ma'am said, I just want to pick up as one summary line, Anupama, is, wait, what did she say? One was the inconsistency. Sorry, I forgot. I'll come back to it if I remember. I think it was about educating this thing. So all in all, very good. You had a lot of audience. You had a lot of audience interaction as well. So I think what you chose was not just interesting.
You remember us discussing that what topic, something that will help us all,
Yes, yes,
because of course we all are learning, and thanks to you, Debosmita. I think our approaches, we want to learn more now. We want to understand if we are doing right. As Vijay ma'am said, in fact, I was about to say the same thing when she started, that we are the advocates for our kids. We'll have
yes.
to put our foot down and tell the parents, no, just do this. This is enough for the child at this point.
Point.
Next step later. Do not
Correct.
bombard with too many things. It is exhausting for the child. It is
Correct.
very exhausting. And for the parent
It is
also.
mentally disturbing for the parent.
Exactly. Yes.
Yes. So I'm sorry. I just remembered what I
It's all
wanted to say.
right.
Don't leave the child for a second also. Don't let the child be within themselves, or not interacting with you. Always go behind the child. A lot of professionals say this, okay? And the moment, as a child's advocate, you put your foot down and say, so the whole day he is not allowed to regulate and unwind. I said, what is this concept of going to the toilet, sitting and playing your game for 20 minutes? You are regulating, you're unwinding, because you cannot do other things at home otherwise. You must leave the child. Nobody's saying go on and on for hours together, but 3, 5, 7 minutes of these breaks for the child is enough for the child to regulate. So don't feel if they are zoning out, if they are by themselves, it is a very big crime that the parent has committed. That is also something that I have been battling very badly for the last 2 years, that we have been told never let the child alone. We have been told never let the child alone. Like, how is the child going to explore, regulate, make those sounds, do those? The child requires to do those so that he can listen when you want the child to listen. It is a very simple calculation.
True. Very true.
I think she has put Kyrie Eberts is also very good on Instagram. Please do check out the talks and the posts during COVID. So that is all in.
Jessie Ginsburg has her own YouTube channel. Please go to the
Okay.
first ones, the ones when they
Okay.
just started. Those are really, really good. Just look at the
Okay.
posts during COVID. They are really good.
Good. Okay.
That is
So,
very
ma'am, like you said, and like Anupama is doing, as SLPs, we hope to support each other, that what is doable through our sessions, what we do, how we can help out each other. I think. Thank you so much, ma'am, for participating today.
so true.
Pleasure is always mine.
Thank you, ma'am. So it is 9:10. Anupama, if you don't mind, should we wind up? I don't see newer things coming in the chat box.
Yes, yes. I am so sorry for the beginning. I was struggling with
No
certain things.
problem. So this is a small token of love and appreciation for accepting this and making it such a lively, fruitful discussion with so much of audience interaction. It was really lovely. It was really lovely.
Thank you
And
so much.
thank you so much. So see you all soon. Have a very happy Diwali and a happy festive period ahead, all of you. Thank you so much. Do get in touch. Do get in touch with the speaker. Get in touch with me if you want to get in touch with her. Anything, any form of discussion that we can help each other is
Always
always,
welcome.
always welcome. Always welcome.
Happy Diwali, everyone.
Happy Diwali, everyone. Have a great time and we'll connect soon again. So, good night. Take care
Good
till
night.
we meet again. Bye bye.